Welcome back, everybody. So this is our continuation of lectures 10, 11, and 12. And we're going to pick up with our PowerPoint and talk about multiple antibodies. So where we left off last time, we had gone through examples of antibody screens. And we know that when a patient has a positive antibody screen, it most likely indicates they have an unexpected antibody, and we need to do panel testing to determine the identity of their antibody or antibodies, because this can definitely impact transfusion. So in the example that we did with our last lecture, we identified an anti-big K in a patient. This is important to know because when that patient needs future transfusions of red cells, we absolutely must make sure that the donor red cell units they get are not only ABO compatible, but they should also lack, in this case, the big K antigen. If we give them donor red cells that have the big K antigen, their anti-K is going to find its target antigen on the donor red cells, and they will have a transfusion reaction. Now, this will not be as severe in most instances as with an ABO incompatibility, but still, they would have a transfusion reactions, and they would have a transfusion reaction, and the donor red cells would not be doing their job, which is to help the patient oxygenate better. So that brings us to our topic today, multiple antibodies. So when we have a patient that has more than one antibody, matching the pattern is absolutely more difficult. And the pattern will not match one specificity. So that's how we have an idea that they have more than one. Varying reactions may also be observed when more than one antibody is present. So meaning different reaction strengths, different patterns of reactivity, etc. So we may have to employ special techniques to help us identify multiple antibodies. And so, for instance, if we have an idea that it could be which antibodies could be implicated, we can go to our panel cells and select additional cells for testing to different lot numbers of panels to find specific examples to prove our point. And we'll be doing that in our next frame. We could repeat the original panel that we did, however, this time using cells that have been enzyme treated. And so hopefully you remember that enzyme treating our panel cells can enhance certain antigens like RH antigens or KID, but also could destroy or eliminate certain antigens such as the Duffys, M and N. That was hard for me to say. We could also repeat the panel after treating the cells with other types of chemicals like sulfhydryl reagents that we talked about previously in lecture 9. And so hopefully you remember sulfhydryl reagents will denature the Cal antigens, big K, little k, KPA, KPB, JSA, JSB. And so some examples of sulfhydryl reagents include dithiopyrital, 2-ME, and AET. So this is just basically some other tools we have in our toolbox to try to eliminate reactions so that we can truly understand what's happening with our patient. So here we see an example of panel 8.3 multiple antibodies, and this example is from our textbook. And so you could see down here how they're already telling us which two antibodies are implicated, anti-Duffy A and anti-E. But what I would like to do for practice is I would like us to go through our rule out method so we can see initially how these multiple antibodies are going to present. Okay, so I'm going to get my pen. And so remember our rules. When we're ruling out, we have our 3 phases of reactivity here. We want to look to the first panel cell where we got negative reactions at all phases of testing. And so when we look at cell number 1, we see 3 phases of testing with negative reactions. So we can use cell 1 to eliminate positive antigens. Okay, so we're going to go over here We're going to eliminate D. We're going to take dosage into consideration. We can get rid of C, big C. Can't do anything with these two. They're not represented. And we can get rid of little e because big E isn't there. Nothing with these. Can't, if we're considering dosage, we're going to not touch those. Big S can be eliminated. P1 stands alone. LEB, LUB. When it comes to big K, I can see that there is a big K positive one down here. Well, I think we'll eliminate big K because this is a rare antigen, and so we know that oftentimes Cal doesn't follow dosage, so we'll eliminate both of those. Duffy B, Kid, and that's it. Okay? So the next cell that we can use to eliminate positives is cell number 2 because we have negative reactions at all 3 phases of testing. Remember, you don't have to re-eliminate antigens that have been previously eliminated. We just want to go for the new ones. So we're going to skip these, skip F, and get rid of CW, get rid of big M, skip the N, can get rid of little s. Nothing here, nothing here, nothing here. We're going to skip the Kid and wait to see if we can have homozygous JKB to eliminate. The next 1, 2, 3, 4, 5 cells we cannot eliminate. Okay, so I'm just going to bold. I don't draw straight. Let me get my eraser. Maybe I'll just highlight them. How's that? Maybe that'll be easier for me. I'm just going to highlight those. So we can't use those because they're positives, right? Okay, and here's a positive here, so we're not going to use that one either. So that'll definitely stand out to help me not use those. Okay, go back to my pen. So the next cell that we're going to use is cell number 8 because this is the next cell where we have all 3 reactions that were negative. And we're just going to look for ones that we haven't previously eliminated. So on cell 8, we can eliminate C, little c. We can eliminate F. Nothing with N. No LEA, no LUA, no Duffy A. And we can get rid of JKB. So we see it's homozygous here, so we can get rid of it there. Okay. And it looks like we have one last cell we can use, cell number 10, which also tested negative at all 3 phases of testing. So can't do anything with big E. We can get rid of big N. Nothing with LEA, nothing with LUA, nothing with Duffy A. Okay, so that's basically all we can do. So now is the time that we're going to try to match our patterns. Okay, so I'm going to change my ink color. I'll try to do something brighter. And you guys know I'm not very good at drawing, so I'm trying. It's with your mouse, and it's really hard to hold the mouse down and it's like bowling. I stink at that too. Okay, you guys get the idea. So we have big E. We'll look at that one. What's our next one? LEA. Yes, okay. LUA, which is, we're kind of going to run into the same thing we ran into last time, so we'll talk about that in a minute. It's much easier if you have a pen and a ruler. And Duffy A. Okay, so what we also want to note is that our patient tested, the auto control was negative at all 3 phases of testing. So we know that whatever antibody or antibodies are showing up, they're A low. Okay, so we want to try to match our pattern. So we're going to first start with big E. So we have a negative, 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 a positive, that fits. But then this, okay, one here doesn't fit. So maybe I'm going to highlight. Go and highlight with maybe a different color. No, I can't highlight with a different color. So I'm just going to highlight the ones that don't fit. So this one doesn't fit. That fits. This one doesn't fit. This one doesn't fit. That fits. This one doesn't fit. Okay. So basically we see that although some of the reactions with the big E fit, okay, there are others where our patient reacted, but the antigen was not present on the cells where the patient reacted. So what that means is it couldn't be due to an antibody against E. So namely, these 4 reactions are the misfits over here. So let's take a peek at our other ones. So Lewis, we know, is normally cold reacting antibody, and so really, we're not going to really worry about the Lewis. It's usually not implicated in transfusion reactions anyway. And similar to last time, when we look at LUA, we could see that this antigen is not represented on any of the screening cells. So what we have to say in that case for LUA is, well, really better if I just go like this, right? Cannot rule out. We don't know anything about it because the antigen is not present, but remind you guys, remember, you can always get a clue about antigen frequency. When we look at the panel and we see that each cell is negative, this is telling us that LUA is a low frequency antigen, which it is, which means most people in the population do not have it, okay? And so antibodies to low frequency antigens are pretty rare, okay? So let's go and look at our Duffy. And I'm going to switch back to my highlighter. So far so good. Negative here, negative there. Okay, this one doesn't fit, okay, because this is positive, okay? So, but I'm going to leave that go. This, okay, I just want to see, so here, this is a positive that before we didn't have, okay? Let's look at those. Here's a positive, which we have. Here's a positive that didn't get detected with our other cell, as is this, okay, negative, and then a positive, okay? So hopefully this will make sense in a minute. So we see that the pattern basically fits except for one cell. So let me just get into a different color ink again, something that's going to stand out. All right. So we see that there, oh, it's a highlighter. Isn't that cool? Okay. You learn something new every day. Okay. So I had highlighted in yellow reactions that were positive, that were missing on our E antigen. And then when we're looking at our Duffy, we see that there is a reaction missing here. Okay, so I highlighted that one in green. And I highlighted these next few because what you can see is the missing positive reaction for E is here. Okay. They're both reacting with cell 5, which maybe is why that one's stronger. And then we can see on cell 6, our E antigen was not reacting. However, the Duffy A is. Okay. Likewise with 7, the Duffy A is being picked up here. And then likewise with cell 9. Okay. So all of the 4 cells that were negative, okay, for E antigen, we can see the Duffy A was positive, and so that could explain these reactions. So I'm just going to maybe box them off. Okay, so you guys see, right? Really helps when you have a lot of colored pens when you're doing this with more than one. Okay, so that is going to pick up those, okay, that we're missing here. Now this, okay, 3 plus is being picked up by our E. Let me change the color. All right, so we can see this one is actually can be picked up here. So, you know, when I look between the two, the E and the Duffy A, it looks like all of the positive reactions are being picked up, and then, you know, the negative reactions are fitting, okay, outside of those. So the negatives definitely fit, okay? So it looks like it could be a combination of both E and Duffy A when I look more carefully at it. But I can't just go by this alone, okay? I really need to prove that it really could be both anti-E and Duffy A. Okay, so let's look at some things we can do. Okay, so one thing we could do is select some additional cells for testing to help us prove that both of these antibodies are present. Okay, and so we go to a different lot number of panel cells and hand pick the cells that we really want to test. Okay, so on this select cell panel, okay, if we want to really prove that this patient has anti-E, okay, right, an antibody to E, we want to hand pick, and you can see they hand pick 2 cells here, cells that have the E antigen but that lack the Duffy A, okay? And so you can see how they found 2 cells that they could do this testing for, okay? And so the reason for this is by testing these 2 additional cells that have the E antigen only and not the Duffy A, if our patient does indeed have an antibody against Duffy A, it will not be reacting with these cells. So if our patient does react with these 2 cells, we know it's due to their anti-E because there is no Duffy A antigen for them to react with, okay? And so we could see by the testing that there were 3 plus reactions with both of these cells. And so basically this is confirming that yes, there is an anti-E, okay? So the cells selected were E positive and Duffy A negative, okay? Hopefully that makes sense because we're eliminating any reactions that would happen due to an antibody against Duffy A by testing Duffy A negative cells but E antigen positive cells. And so it's proving they have the anti-E. Okay. I'm going to go back and show you guys one more thing. So we could actually try to do this the opposite way as well. So we could try to find, we could test some additional cells, and I'm not sure if there are any on here that are going to fit this. So let me get a different color pen. We could also try to do it the opposite way. Okay, so look for maybe some cells to test that have the Duffy A antigen, but not the big E to prove that they have the Duffy A. So let's see, can't use any of these. So let's see, here's one that has Duffy A, but E is also there, so that's not going to help us, okay? This one, no. Okay, here, this is one. So here we see cell number 6 has Duffy A antigen, but lacks the big E, okay? So this is one we would want to test to prove they have an antibody against Duffy A, and we could use the very next cell as well. So we have Duffy A and no E, okay? And there's actually even a third one we could do, okay? If we wanted to, okay? So these 3 cells we could test, and if we got positive reactions, then it's going to prove, you know, positive reaction at AHG is going to prove that yes, they have the Duffy A separately as well. So hopefully that makes sense. So, you know, we want to eliminate one antigen and have the other one present for both antibodies, okay? And that way we can prove that, you know, when we get positive results, so let's say, let me get my black pen. So let's say this reacted 3 plus, 3 plus, and 3 plus, okay. And let's say negative. I'm not going to fill all of this out because it's tedious the way I have to do it. Okay, but hopefully you see if testing these cells, okay, so green, okay, so green proves anti-Duffy. Oh, this is so hard, guys. Sorry, anti-Duffy A. Okay, the green ones. Okay, because there's no E antigen, so the anti-E reaction is eliminated. And then if they react like they did here, then it's going to prove that they have the Duffy A. Okay. All right. So let's talk about another example. Okay. So let's apply this in another way. So let's say we have a patient, and when we did our panel testing, it looks like our patient may have both an anti-big K and an anti-big C. So what we would want to do is, like we did in our last example, go to a different lot number of cells and hand pick some cells to prove each antibody is there. Okay, so what we would want to do first, to prove the anti-C, okay, we would want to find cells negative for big K antigen but positive for C. So this is going to eliminate any potential reactivity from the anti-K. Okay, so maybe 1 or 2 cells for that. Then we would want to look for a few cells that are negative for the C antigen but have big K. And then that's going to eliminate any positive reactions from the patient's anti-big C. And so we could prove each individually that both are there. And it's similar to the example we just did. So if the patient reacts with both sets of cells, then it helps to prove that they absolutely do have both an anti-big K and an anti-big C. Okay, so I picked this panel, and I want you guys to help me. Oh, if we were in person, you would be helping me, but we know that's not happening, so we will try our best. All right, so first, are there any panel cells negative for K antigen but positive for C? Okay, so we're going to look at our K. Well, here's one that's negative for K, but we have to go over and see. That's not going to work because it has big C as well. Here is big K. Let's see, yes. Okay. So that's going to work. So what is that? That is cell number 3. Okay, let's see if we have one more that we could do. And we do. So if we look at cell number 7, big K is there. Big C is not. Okay, so 3 and 7. Okay. And then secondly, I'll use a different color. Are there any panel cells negative for C antigen? I did this backwards. I did this one first. Oh, let me get my eraser. Oh, guys, it's been a long day. Sorry, put it backwards. So we did number 2 first. We picked cells negative for C and positive for K. And so these are 3 and 7. Okay. So now we'll go backwards and do number 1. Okay, so now we're looking for panel cells negative for K but positive for C. Okay, so let's see cell number 2. Yeah, that works. Negative for K, positive for C. Okay, so that's cell number 2. Let's see if we can find another one. Negative for K, positive for C. That was like almost too easy. Oops. Cell number 4 fulfills. Now when we look at cell number 5, we see it's negative for K. Dun, 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 dun. Can't use that one. Also negative for C. And same with cell number 6. It's negative for K, but it's also negative for C. So guess what? That wouldn't react with either of the antibodies. And looks like 8 and 9 are the same way. And it looks like cell 10 could help us in this case. So we have negative for K and positive for C. Okay, so it looks like 2, 4, or 10. And they're usually going to do 2, at least 2. Okay, 2, 4, or 10 can help us. Okay, so hopefully that makes sense. Now, if our patient reacts with cells 2, 4, and 10, and then also reacts with 3 and 7, it's proving that yes, they do have an anti-K and an anti-C. Okay, so we are going to move on and talk about another tool in our toolkit in more detail, and these are the proteolytic enzymes. So enzymes can be used to eliminate or enhance antibody activity, and we've talked quite a bit about this already. So remember, Duffy and M&N antigens are destroyed, so they're going to eliminate reactions. Enzyme-treated cells would eliminate any reactions due to Duffy or M&N antibodies. S and S are variable. Just don't worry about them. Just remember Duffy and M&N are destroyed, while Rh, KIT, and Lewis antigens are enhanced. So when they're doing enzyme treatment, there's a one-stage test where enzymes, red cells, and actually serum are simultaneously incubated together. Or there is a two-stage test where panel cells are pre-treated with enzymes, washed, and then used as they normally would be used. So on this slide, I've taken a picture of panel cells, and these are actually panel red blood cells that you can see are a different percentage. They're 0.8%, and they're actually used when we're doing a panel using the gel method. And so this is a double panel. So one set of cells comes without the enzyme treatment, and then the same exact cells were treated with Fycin by the company, and they are included separately. And so you can see here Fycin treated, and then of course here is the antigram, and the antigram is indicating, you can see here in red, Duffy antigens would be destroyed when using the enzyme treated cells. The M and N would absolutely be destroyed. So this is just you know, one example of one company's panel cells. And here's a close-up of the antigram from the panel cells. And so remember, S and S, big S and little s, can have variable reactions after enzyme treatment, but M and N and Duffy would absolutely be destroyed. So here, this is panel 8.5 from our textbook. And so this is the same example with the multiple antibodies where we had the antibody against big E and we thought antibody against Duffy A. And so they're basically showing how if we were going to follow up that original panel, and so what you can see here, let me just get a different color pen. And so I'm just going to draw a little line down here. I'll try to be as straight as I possibly can, which isn't very straight. We see the original results here, 37 AHG and check cells. And so these were the reactions initially, okay, that were positive, positive. And when we looked at this panel previously, we saw that some of the reactions were from the big E, and we thought some were from Duffy, okay? And so you can see the pattern of reactivity here, how cell 3 contributed to this, cell 5 was positive here, and then we can see the Duffys also. This is kind of what I did with you already on the previous panel. So to try to figure out if there definitely were two different antibodies here, they repeated the panel using the Fison-treated cells, the enzyme-treated cells. And so what we see here, when you look at the AHG column, we see some reactions stayed, okay, and others were lost, okay. So this was lost, this reaction stayed, these next two were lost, excuse me, as was cell number 9, okay. And so really the only reactions remaining are these two. And if we look over to RE, we can see that these were the positive reactions contributed by the big E antigen, okay. And so basically, let me get a different color. These reactions here that were from the Duffy, anti-Duffy A, we could see that these reactions, we're going to look at in a minute, were eliminated when we tested using the enzyme-treated cells. So that one's gone, these two are gone, and this one's gone. Okay, so that's an example of how using a panel with enzyme-treated cells eliminated the Duffy A antigen, so we lost the reactivity, the reactions basically that were due only to the anti-Duffy A. And it enables us to prove that, hey, yes, okay, there is an anti-E here because that is all that's reacting with the enzyme-treated cells. And oftentimes, following enzyme treatment, remember RH antigens reactions can be enhanced. Sometimes you might even see stronger reactions when you're using the enzyme treated cells, not necessarily here, but that can happen. So we're going to move on to a different topic. So we're going to move on to a different topic next, and we're going to discuss antibodies to high-frequency antigens. So remember, a high-frequency antigen is one that is found in most people. And so basically it means 98% of the population or more have the antigen. We want to suspect an ALO antibody to a high-frequency antigen when most of the panel cells are reacting with our patient. And we may have to do additional testing to confirm the presence of the antibody. So sometimes enzymes, as in the last example, to either enhance or destroy antigens, or dithiothriotol and other such sulfhydryl reagents to destroy KEL antigens. Table 8.5 from our textbook lists some of the high-frequency antibodies to high-frequency antigens and some of the clues that we may have when we're dealing with this type of. So when we have our cold reacting antibodies, you know, we want to suspect big I or big H. So remember, the big I is found on all adult cells and big H is found on everybody, okay? And then some of these other ones, P, P1, these are some high-frequency antigens too. Negative with Fison-treated cells, Chido, Rogers. Some of these are some oddball ones. And then, for instance, we could see negative with DTT-treated cells. We're going to see our KEL antigens show up here, JSB, KPB, and little k. So remember when we talked about the KEL system in, excuse me, lecture 9, the second antigen of antithetical pairs is the high frequency one. So big K is low, little k is high, KPA is low, KPB is high, JSA is low, JSB is high. So you can see that DTT treatment is going to disrupt those antigens, and so we would then get negative results. And so these are basically just some clues of things that we could do. Let's see, stronger reactions on cord blood cells. Remember little I, because that's found on all cord blood in children less than 2. Race association, definitely with blacks. The U, anti-U. And so that's just a couple of different tips. Let's dig in and look at an example of an antibody to a high frequency antigen. Okay, so first of all, what are our clues? When we look over here to our 3 phases of testing, we see nothing at immediate spin or 37, and reactions are only showing up during the AHG phase. And when we look here, we see, wow, okay, reacting with every cell except number 7. Now, how do I know this isn't an autoantibody? Let's look to our patient cells. Our patient control is negative, so it is not an autoantibody. And so basically, they're telling us, if we went through the rule-out method, that this is an example of an antibody against little k. So let's look at little k, and we see that little k is absent just from this cell, and that's why there was no reaction. And we know that little k is a high-frequency antigen. So was the rule of 3 met? Remember, the rule of 3 is really very important, so that we know this is not a random occurrence. And while we have many, many antigen-positive cells that reacted with our patient, we really only have 1 antigen-negative cell that did not react with our patient. So to meet the rule of 3, we would need to go to another panel and hand pick 2 more cells that are negative for the little k antigen and test them to get our 3 negatives. Okay. If an antibody screen was done and one of the screening cells happened to be negative, that one could count. Okay. But rule of 3 was not met, so we need to fulfill that. And one more thing, just remember, if this truly is an antibody against little k, we could phenotype the red cells of this patient. We take anti-little k, anti-serum, test it with this patient's 3 to 5% red cells. There should not be agglutination. This patient should be negative for little k antigen, and it's one more way to confirm, okay, that they have anti-little k. So I want to go back because I just wanted to mention something related to our example before when we're looking at this one, okay, and it has to do with the rule of 3, okay. So, we know that enzyme treatment, we lost the reactions of our anti-Duffy A in this other example, and that we maintained the positive reactions that were due to the anti-E. However, I ask you, was rule of 3 met in this case? Dun, 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 dun. No. Okay, so in this case, we would need 1 more E antigen positive cell to test with our patient, okay, to provide the 3rd positive reaction. So we should really go hand pick an E positive antigen cell from another panel, and maybe we don't have to use enzyme treated cells. We could look for an E positive that lacks Duffy A, okay, to prove that. Okay, so getting back to our anti-little k, this is a picture of an antigram that I took in the good old days. And if it looks pretty small on your screen, you may want to maximize your screen to see it as large as possible. And so this is just showing you what I would do if I were working in the lab and I now needed to go find, from our last example, we need 2 little k negative cells to test with our patient to get 3 antigen negatives that don't react with our patient. So I'm going to look at this panel and I'm going to find the cal antigens, and here is little k here. So let me try to, maybe I'll highlight it. Let's see. Maybe that'll work better. Like I want to try, I can't turn my mouse around to make it better. Maybe I won't. Let's just do the pen. Let's pick a different color. All right. So here's our, oh God, bear with me guys. I'm really trying. Okay. So we want to try to find a little k negative cell to test. So we can see, we know little k is a high frequency antigen, and we can tell just by looking at this panel because most of the cells have it. And so by the time I get to the very, very bottom, you see this one? Cell 22 is negative for little k. This is a cell I could hand pick and test with my patient to get a second negative cell. And then I'm going to have to go to another panel and find a third to meet the rule of 3. So here we go. Here's another panel. Maybe this picture is a little better. Okay. And so once again, here's our little k. Maybe it's just easy if we go through this way. And so, aha, there's one I could use, cell number 6. So I would take this cell number 6 from this panel, the cell number 22 from that previous panel, set them up, test them with my patient, all 3 phases of testing, and if they are negative, then I'm going to fulfill my rule of 3, which means it's not a random event, and my patient does indeed have anti-little k. Oh, I guess I'm beating a dead horse here. bad saying. Okay, let's see which one we could pick here. Looks like cell 22 again. Okay, just so you get the idea of it. So I'm hand picking what I need. So the next topic we're going to discuss are high titer, low avidity antibodies. So these are antibodies to high frequency antigens, just like we saw in our previous example, except these antibodies react very weakly. And most often they're only going to react at AHG phase. They're usually not implicated in transfusion reactions or HDFN. And they can really be a nuisance when we're doing our panel testing. So this is table 8.6, which is giving some of the characteristics of these high titer, low avidity antibodies. And you can see inconsistent reactions that are sometimes not reproducible. So maybe I test my patient with a panel and I get a positive reaction with cell number 1, and I repeat my testing under the same conditions with the same enhancement, and all of a sudden now cell number 1 is negative. So remember, they're usually not clinically significant, often found with other antibodies. We can have variable reactions among our panel cells. They are usually not enhanced with the use of our potentiators. They don't react with the patient's own cells, the autologous control. Weak reactions at the antiglobulin phase to the point where we may have to look at them microscopically to see the positive reaction. And if we were meeting face-to-face in lab, whenever you have an extremely low or extremely weak reaction in tube testing, I may have mentioned this to you all previously, we could actually take a drop of the suspension out of the tube and put it on a glass slide and look at it under the microscope to see if we're actually seeing the clumping. They look like clusters of grapes of the red cells under the microscope. Reactions may be weaker on older cells, and titration inhibition may be useful techniques in classifying and identifying these antibodies. Honestly, most hospital laboratories are not going to take the time or the energy to really try to do this on their own. They're going to send this to the American Red Cross or some other reference lab to figure out what they are. All right, so we're going to do the opposite next of what we did looking at antibodies to high frequency antigens. Now we're going to look at antibodies to low frequency antigens. They may occur alone, or they might be suspected when we do an antibody screen and it looks like the patient has no antibodies, but we're thinking of transfusing our patient with a certain unit of donor red cells, and we do a cross-match test for that. So we haven't talked about the cross-match test yet. It'll be coming up in module 3, no, exam 3 material. We're in module 3 now. It's kind of hard to keep track of it. But let me just tell you a little bit about the cross-match test. When we have someone in need of a transfusion, we call that person the recipient. And so if we have an ABO compatible unit of red cells that we're thinking of transfusing in that patient, we can take some of those red cells and make a 3 to 5% suspension of them and test them with the recipient, the person we're thinking of giving them to's plasma. And it's just like every other tube testing, it's the same thing, same quantity. So it would be 2 drops of my patient, my recipient's plasma, and 1 drop of the donor red cells, 3 to 5% suspension. And we're going to look to see if they agglutinate, okay? So we don't want them to, okay? So with the cross-match test, negative results mean it would be okay to transfuse these cells in the person. So when someone has an antibody to a low-frequency antigen, the antibody screen may have been negative, so we don't think they have an unexpected antibody. However, when we just happen to pick a unit of donor cells to cross-match with this patient, those donor cells happen to have this low-frequency antigen just by chance on the red cells, and it's now reacting with our recipient. Only 1 reactive cell suggests this type of antibody, and common antibodies that are low frequency or antibodies to low frequency antigens include anti-CW. So remember, this is one part of the RH system. Some of these other ones are those other blood group systems that we didn't really even talk about. Vel and some of these other ones. KPA, we did talk about. LUA, we've talked a lot about, especially today when we saw how all our panel cells lacked that antigen. And so those are just a couple of examples. Okay, so we're going to move on to a different topic and talk a little bit about enhancing weak IgG antibodies. Okay, so when we suspect that our patient has a weak antibody, there are quite a few different things we can do to try to enhance the reactions so we really truly get true reactions and we identify accurately. So we could repeat our test, either our screen or panel, with a different enhancement medium, and we did this today, such as enzymes, or with maybe a different potentiator. Okay, so maybe I usually use LynnC, but if I suspect that my patient's antibody is weak, maybe I want to switch and try it with PEG now. We want to check for dosage on weak or missing reactions, okay, because remember, with some antibodies, heterozygous expression of the corresponding antigen can lead to weaker reactions. Select different cells from a new panel. Incubate longer. Instead of incubating 15 minutes, maybe I want to double it up to 30. Phenotype our patient. Patient's red cells, if not recently transfused, to try to prove it. Or increase serum to cell ratio within limits of our reagent. So maybe I need to add another drop of my patient's plasma, bump it up to 3. Okay, so we're going to move on to a new topic, and we're going to move away from clinically significant warm reacting antibodies and talk a little bit about cold ALO antibodies. And some of this we talked a little bit about when we were doing or looking at the examples of antibody screen tests in the previous lecture. So remember, cold, it's reacting at room temperature or colder. ALO, directed to antigens of someone else. So these are class IgM antibodies that react during immediate spin cross-matching and sometimes at 37 degrees. So as we've discussed previously, sometimes those room temperature reactions can carry through to 37. They are not clinically significant, and some common ones, anti-P1, anti-M, anti-N. They have variable reactions. So to enhance the reactions, we may want to incubate a little bit, but we want to incubate at a cooler temperature, below room temperature. So what this means is we combine our patient's plasma with cells and we actually put them in the refrigerator at 4 degrees, okay? To avoid these reactions, we may need to neutralize so that we can determine if there is a clinically significant antibody present along with this cold ALO antibody. Okay, so here's what happens. They can mask the presence, at least at immediate spin testing, right? If something else is there, we want to eliminate the reactions from these antibodies. Okay, so neutralization actually involves adding soluble antigen to the patient's serum or plasma, and then that ALO antibody is going to find its target, okay, and bind to that antigen, form an immune complex. So then when we centrifuge, the immune complex would be in the bottom of the tube, removed. We're going to take that serum and plasma that is now free of this cold ALO antibody and now test it to see if there's something clinically significant there that is an IgG antibody. Here we see panel 8.8, which is showing a cold reacting ALO antibody. Okay, how do we know it's ALO? Let's look at our patient cells. No reaction, no autoantibody there. Okay, how do we know it's cold reacting? Let's look at our phases of testing. So at immediate spin, we see the reactions are 2+. They carry through to 37 and even to AHG, but they become much weaker. Okay, so this is telling us this is a cold reacting ALO antibody. Okay, and so basically it tells us this down here, and this happened to be an anti-LEB. So if you wanted to go through and do the elimination, you have a couple cells you could use. Cell 3, well, let's do it real quick. Okay, let's look at cell 3. So remember, we have to look for ones that are negative through all phases of testing. Okay, so I'm going to get rid of D, and some of these we know don't react. At cool temperatures, got rid of N, get rid of little s. E1 is by itself. LEA. Okay. LUB. Okay. We're going to eliminate both of these, okay, because we don't usually consider dosage for the Ks because it's really hard to find them homozygously. No Duffys. I'll skip those. Okay, we're going to go to this cell next, which is negative at all reaction phases. We're only going to look at what's left. Okay, little e, F. Can't get rid of M, can't get rid of big S. No to LEB, no to LUA. Duffy A. And nothing there. Okay, so we'll go here. Okay, we'll get rid of M on this cell. Nothing. Duffy B. And JKB. And then here. Okay. No. And JKA. So you're going to see that we have quite a few specificities left. And remember, we know that some of these cells really do not react at, only some of them are known to react strongly at immediate spin. So we look at the C, and we know that the RH antibodies usually react at warmer temperatures, stronger. Same with CW. The S, pattern doesn't really fit. Let's look at LEB. And we know that anti-LEB is an antibody that typically does react. Oh, sorry, I'm really drawing badly. Positive here, positive there. Positive, positive, negative, negative. Positive and positive, positive and positive, negative, negative. It's a perfect pattern match. And we know that these Lewis antibodies typically do react at, they're considered cold reacting antibodies. Okay? So what is the clue that it is an ALO antibody? I think I told you guys this first. Patient is not reacting with self. And so we're going to suspect this anti-LEB. And they actually make something called Lewis substance. So if we really wanted to remove the reactivity of this patient's anti-LEB, we would take this patient's plasma, add some Lewis substance, which is basically Lewis antigen. This cold reacting ALO anti-Lewis is going to bind to its soluble antigen that we added and form an immune complex and separate. So we centrifuge, and then we're going to take the plasma off the top that is now free of this cold reacting ALO antibody and test with a new panel to see if there isn't something underlying that is clinically significant. All right, so we're going to move next to autoantibodies. Autoantibodies usually react with all reagents and self. The patient control, also known as the autocontrol, is going to be reactive, and donor red cells regardless of the antigens present. The autocontrol and the DAT are positive. Okay, something is coating these cells, an antibody. It's important to identify underlying ALO antibodies when an autoantibody is encountered, because autoantibody reactions could be masking a significant ALO antibody which is present. We're going to look at an example of this. So there is a technique that we could do called adsorption. And this adsorption technique is used to remove the autoantibodies from the patient's plasma. And then once the autoantibodies are removed, we're going to retest that patient's plasma to see if there are any ALO antibodies. So similar to the last example. So cold autoantibodies react during immediate spin and have positive autocontrol and DAT, and this is due to complement coating, not IgG. Cold autoantibodies may occur in individuals with a history of mild anemia. Mycoplasma pneumoniae is a big one. Remember, auto-anti-I after Mycoplasma pneumoniae infection. Remember, the big I is seen on all adult red cells, or infectious mono. So in addition to auto anti-I, there could be anti-big H and a combo anti-IH. And so we can use cold panels to help identify them. So this is panel 8.9 from our textbook demonstrating a cold autoantibody. Let's look at what's happening. Okay, so we see when we look across, the strongest reactions are at immediate spin, which is why we think it's cold. Okay, and when we look down, we see every cell is reacting, including the autocontrol. This is the big clue why we think it's an autoantibody, because the patient is reacting with himself. Okay, so you can see here how it's impossible for us to tell if this person has another antibody that could be clinically significant beyond this autoantibody, because it's masking there's a positive reaction with every cell. So we need to basically eliminate these reactions so we can see if there is something else there. Okay. So these are some examples of cold panels that we could set up to determine common autoantibodies, and you see that the testing is done at 4 degrees C. So what they did was screening cell 1, screening cell 2, auto control, patient control, cord blood cells times 2. Remember, they come from the umbilical cord of a newborn, A1 cells, A2 cells, okay, and group O, individual cells. All right, so we're going to take this patient's plasma, 2 drops into each one of these ones that we're testing. They didn't test these 2. And then 1 drop of screening cell 1, screening cell 2, patient cells, cord blood cells, and centrifuge them after we've incubated them in the refrigerator at 4 degrees C, okay, for maybe 10 or 15 minutes, and see what we get. And so what we see happening here is 3+ with screening cell 1, 3+ with screening cell 2, 3+ with the patient's own cells. That's why it's auto, okay? No reaction with the cord blood cells, and they did not test A1 or A2 cells. And basically, what this is telling us is this is most likely an individual with auto anti-I, anti-big I. So why? I wrote it down here already. all of these are adult cells, right? And we know that I antigen is present on all adult cells. This patient did not react with the cord blood cells from an infant, which we know infants have little I, correct? No big I. And so that's why we're seeing the negative reactions here. So basically, this is confirming auto-anti-I, since it reacted with everything but not with the cord cells. Okay? Oops, wrong thing to do. So let's look at cold panel B. So in this case, they tested screening cell 1, screening cell 2, auto control, 2 different cord cells, A1 cells, A2 cells, okay? And the setup is exactly the same. 2 drops of the patient's plasma into each tube, and then 1 drop of the corresponding cells. Incubate them together in the refrigerator at 4 degrees, and then centrifuge them following incubation and read. So what do we have? 3+ with screening cell 1 and screening cell 2 and patient's own cells. Okay? Now, this is different because with this example, we're seeing a reactivity with the cord blood cells, okay, which we did not see up here. We also see reactivity with our reagent A1 cells and with the A2 cells, but look at what's interesting. Stronger reaction with A2 cells than with A1 or the cord, okay? So this is actually an example of a patient with an auto-anti-I big H. Okay, why do we say so? H antigen is present on cord cells. We see we got weaker reactions there. When we look at the A1 cells compared to the A2 cells, we see the A1 cells had a weaker reaction than the A2. And if you think back to when we discussed the H antigen, that the blood group that has the most H antigen is type O, followed by A2. So this auto-anti-IH is reacting more strongly with the A2 cells because they possess more H antigen than A1 or cord cells. Okay? So it's just a way to confirm what these cold autoantibodies are. So how do we avoid the reactions? We want to use a monospecific IgG AHG reagent rather than a polyspecific reagent when we're doing our testing. Skip immediate spin cross-matching and testing at 37. Just do an AHG phase only. We can eliminate reactions if we use bovine serum albumin as a potentiator instead of LynnC. And we can also eliminate these reactions if we pre-warm all of our tubes to 37 degrees. We're going to avoid the reactivity of these cold reacting autoantibodies. If this doesn't work, there is one last thing we can do, the technique called adsorption. And adsorption basically is where we use red cells that have known antigens to help remove antibodies from patient plasma. And we're going to talk more about that next. Oh, I didn't go ahead. Okay. So this is a diagram from our book that shows the pre-warming technique that we can do. So we can incubate serum and red cells separately, okay, for our panel testing at 37 degrees for about 10 minutes. And then following incubation, set everything up. Wash 3 times with saline before we add our anti-IgG, and then we're going to eliminate the reactions from that cold autoantibody. So, life is difficult at times, as we well know right now due to everything happening in our world. However, in blood banking, it can become difficult too because there are times when patients have warm reacting autoantibodies. They are actually more common than cold autoantibodies, and they can result due to warm autoimmune hemolytic anemia, which can be of unknown cause. That's what idiopathic means, or could be the result of a disease or medication the person is taking. How do we know? Once again, most panel cells are going to react, but the big thing is the auto control will be reacting also. So once again, using albumin as a potentiator can decrease the reactivity of the autoantibody, but we need to eliminate these reactions once again because we want to see if there is an ALO antibody present as well that we're missing, because this is the one that could impact future transfusion success. Most warm autoantibodies are directed to the Rh system, especially the little e antigen. And so here's what happens. Patient has an anti-little e antibody, and they also have the e antigen. So hence autoantibody. Their anti-little e is binding their own little e antigen. So sensitization is happening in vivo. The DAT is positive. Providing E-negative red cells may increase red cell survival in chronic hemolytic situations. And medications can also cause formation of warm autoantibodies. So this is a chart 8.12, which lists some medications that are sometimes associated with the formation of autoantibodies. And so maybe some of these are antimicrobial agents, and so, you know, not in everybody, just sometimes. So here we see panel 8.10, which is an example of a warm autoantibody. Okay, so let's take a look at a couple things. We see that no reaction at immediate spin or 37. When we get to AHG, however, look at this. Every cell is reacting. If we were going to stop here, we might think, oh, they have a warm ALO antibody to a high-frequency antigen. However, this is not the case because of the patient or the autocontrol. The patient is agglutinating their own cells, okay? And so this is why it is not an ALO antibody to a high-frequency antigen. It is an autoantibody, okay? So it's reacting with every cell. We need to eliminate these reactions so that we can test this patient with a panel and find out if they have some ALO antibody that's being masked or hidden by the autoantibody. The technique that we use is called adsorption. So, as I mentioned, warm autoantibodies could potentially mask or hide ALO antibodies. We need to remove the warm autoantibodies from this patient's serum so that we can test their serum with a panel to determine if they have the ALO antibodies. There's a couple of ways we can do this. Patient red cells can be pre-treated with dithiothriotol or a combination of enzymes and dithiothriotol, which is called Z-Zap. And basically, Z-Zap removes any antibodies that are attached to the patient's red cells. Okay, so it's basically going to break them off, and the red cells are free. After we treat with the Z-Zap, we're going to go through an adsorption, okay, to remove the autoantibody. And we're going to look at a slide of this in a minute, which is going to help. And then following the adsorption, okay, the autoantibody would no longer be in this patient's serum or plasma. We're going to retest the panel to look for our ALO antibodies. So that is the concept. Let's look at a picture. Picture's going to help with this one. Trust me on this. Okay. So here, when we look at the picture, we see the patient's red cells, and we see that the dark antibodies here are the autoantibodies, and this sensitization happened in vivo, so they are affixed to this patient's red cells. We need to remove these autoantibodies. We need to break them off of this patient's red cells, and that's what the Z-Zap is going to do, okay? So we use the Z-Zap, we separate the patient's red cells, treat with the Z-Zap, okay? Break off these antibodies. You can see here how they're being broken off, okay? So separate patient red cells. Now we're going to add the patient's serum, okay? Once we've removed these let me go back. The first step is we need to treat this patient's red cells to remove any of the autoantibodies that are bound. And we're going to centrifuge this and then basically throw away the plasma and just keep the cells in this case. So you see how the cells are now free. They no longer have the autoantibody attached, okay? Now, we're going to add back in some of the patient's serum. Remember, this patient's serum has the autoantibody in it, and it may have an alloantibody, which is designated by the green here, okay? So what happens, okay, when we add the cells to the patient's serum, any autoantibodies that are present in this patient's serum now have a chance to bind to this patient's red cells, okay, because we got rid of these initial ones. So we're going to remove any free autoantibodies in the patient's serum, have them attached to the patient's own cells, centrifuge down, and we're just going to remove the plasma now and throw out the red cells with the autoantibodies attached, because now basically this serum that was in the tube is free of the autoantibody and only has the alloantibody present, okay? So we're going to separate the serum for the panel. This is what we're going to use to test for the panel. Throw away the red cells that have the autoantibody attached. This is what we use for the panel testing, and we're going to be able to identify this underlying alloantibody since we're able to remove the autoantibody. So adsorption basically removes autoantibodies from patient serum. There are a couple of ways to do it, and don't worry too much about memorizing these, but there's rabbit red cell stroma, we can use our patient's own cells. We're going to look at a couple ways to do this, but there's a variety of ways to do it. Okay, so firstly, we're going to look at an auto adsorption, and we kind of looked at this already, but it's a little confusing, so it's not going to hurt to review it one more time. So firstly, we remove serum. We treat the patient's red cells, just like we did in the last picture, to remove any autoantibodies from the patient's red cells, okay? And we're going to return the patient's serum to the treated red cells that no longer have the autoantibody attached, and we're going to incubate them 30 to 60 minutes. Remember, these are warm reacting at 37 degrees. This is going to give any autoantibodies that are present in the serum time to bind to the red cells. And remember, once those autoantibodies are bound to the red cells, they are free from this serum, okay? So we're going to centrifuge, just like in the last example. The red cells get tossed. We don't want them. But now we have the serum that is free of the autoantibody, and we're going to use it to test to see if this patient has an alloantibody. So very similar to the last slide. We could also do something called a differential or allogenic adsorption, okay? And so in this case, they use 3 different cells with known phenotypes. And so you can see here what they picked. Big R1, K positive. You know, they picked 3 different phenotypes, okay? They're going to test each one of these cells with this patient's serum or plasma in a different tube. And the hope is that the autoantibody is going to find its target on one of these cells, okay? So we incubate them for 30 to 60 minutes. Same rules apply. We're going to remove the serum now and test it with panel, but now we have to test 3 different ones, okay? Because we're basically guessing. We're trying to guess which cell is going to be able to remove the warm autoantibody out. Okay, so the autoantibody in the patient's serum will bind to a corresponding antigen that's present on one of these 3 allogenic red cells, removing it from the serum. This serum is free of the autoantibody, and now we can test for a panel to see if there's an alloantibody. So adsorption can be with the patient's own cells that have been specially treated, or it could be with allogenic cells where we're using known phenotypes to try to remove okay, that autoantibody. So this is an example of a panel that I made up to try to show you the importance of this, okay? So in my example, we see the initial panel testing here at 37 in AHG, and we see how every cell is reacting, including the patient control, right? So we know it's a warm autoantibody. And so basically we went through an adsorption. Maybe we used allogenic cells, or maybe we used the patient's own cells. But that adsorption was done to remove this autoantibody from the patient's serum. We then take the adsorbed serum that is now free of the autoantibody and do a panel. And look what we have. Now we see we have negatives, positives, some negatives, positive. There was an underlying allo antibody here that we would have missed if we did not do the adsorption. And so we could go through and, you know, do the identification technique like we usually do to figure out which allo antibody this patient had. I'm not going to do that with you guys because this is kind of a small example. Or should we? We're going to be doing more of them later. Okay, but this is just to show you the importance. Okay, so how now we could go through and do our rule out method and identify what antibody that was underneath ALO. Okay, so a couple of other techniques we need to discuss include elution. Elution is sort of the opposite of adsorption. So adsorption basically removes an antibody from a patient's serum or plasma. Elution is the opposite, okay? So when we have a DAT that's positive, we basically, let me draw a picture. We basically have a red cell. It's not very round. Oh, gee, I should just quit while I'm ahead. Okay, there's my red cell, right? And okay, that's what's causing the positive DAT, right? We have sensitization that happened in vivo, which is why the DAT is positive, okay? We want to detach. We want to break off these antibodies to find out what their identity is, okay? Once they're attached to the red cell, we won't be able to do a panel and find that out. We need to physically remove these antibodies from the red cell, and then we can test them in a panel, okay? And so the technique we use to do this is called elution. And so once we are able to break the antibodies off and they are in a liquid, that is called the eluate. So we can then test the eluate just like we would patient serum or plasma in a panel to identify what antibody was attached to that patient's red cells. This is most often done when we have cases of hemolytic disease of the fetus and newborn, because the infant cells, you know, have a maternal antibody attached, and we want to find out what antibody that is. This is a great picture I found on the internet, which basically describes elution. So in that blood sample, there are red cells that have antibodies attached. The sensitization happened in vivo. So we're going to add some reagents to the red cells, and basically the reagents are going to break off or dissociate the antibody from the red cells, okay? The red cells get trashed. We no longer really need them, okay? But these are in a liquid called the eluate, and we're going to take that eluate liquid and test it with our panel cells to try to find out the identity of this antibody. So hopefully that makes sense. So methods we can do for elution: glycine acid, heat freeze thaw, either methylene chloride or chloroform, or I should say ether, not either, ether. So there are chemical methods to disrupt that antibody and break it free from the red cell. So here's our summary. we have a sensitized red cell. This sensitization happened in vivo. We see the IgG antibodies attached. Through the elution technique, we're going to remove these antibodies from the red cell. They are now free in a liquid called the eluate, and we're going to use that eluate and we're going to test it just like we would patient serum or plasma with our panel cells, and we're going to get different reactions at our 3 phases of testing, and then we can go through our rule out method like we normally would and find out the identity of this antibody that was affixed to these red cells. All right, so we'll finish this unit up and talk about briefly some other problems. So other problems that can exist. Phenotyping red cells that are coated with IgG can be a challenge. Think, what is phenotyping trying to determine? Answer, antigens that are present on the red cell. Well, if the red cell is coated with IgG affixed to it, we may not be getting accurate phenotyping results because our antiserum may not be able to get to the antigen we're trying to identify that's present. Treating cells with chloroquine diphosphate will dissociate the IgG from the red cells without harming antigens, and then we can go ahead and phenotype. And that does it for this unit. So this is very, very important stuff. I know it tends to be a little bit confusing. Please review it, and in the next lecture we're going to go through some more panel examples. It's really important that you all understand how to go through the rule out method and eliminate things and match the pattern. So please make sure you understand that, and then in the next unit we will do some examples, and I'm going to be assigning you guys some panels to do as well for practice. So take care, and I will talk to you guys next time. Oh, one other thing. If you would like to hear someone else describe this whole process, the blood bank guy has a great video on it. Okay? Take care.